So let's go ahead and get started. Good evening, everyone. Welcome to Tea Time with an Epilepsy Specialist. Those of you that are here for the first time, thank you so much. You're in for a great evening. And for those of you that are joining us again, thank you for coming back. I'd like to remind everyone that tonight's session is being recorded and will be reposted on our social media platforms. When we get to the question and answer portion of tonight's session, please keep yourselves muted. I will be calling on you if you have a question. You can use the raise your hand feature to let me know that you have a question. But if you have trouble finding that feature, you can also submit your question into the chat and I can read the question for you, or I'll call on you and you can read it to the doctor, whichever you prefer. And we need to give a huge thank you to our sponsor this evening, which is Greenwich Biosciences. We're so grateful for your sponsorship. And with that, I would like to introduce to you to Tanya Talton from Greenwich.
Well, hello, everyone. My name is Tanya Talton, and I'm honored to be speaking to you virtually on behalf of Greenwich Biosciences and our entire team. As a sponsor of Tea Time, Greenwich Biosciences is proud to partner with Epilepsy Florida for events like this to help people stay connected in this virtual environment. We are united in what we're trying to accomplish here today, and that's to raise epilepsy awareness, to have a positive effect on care, on research, and on the lives of those who are being impacted by seizures. There are so many families who wake up every day to the reality of epilepsy. There are people listening right now who have been fighting against epilepsy their entire life. And there are others who are not able to join us today. But as a community, we never give up the hope that one day we will overcome the challenges of living with this disease. And this is what drives us. You may know us best as a company researching and delivering FDA-approved cannabinoid medicines to help address serious conditions, but also our focus is you. Patients and families are at the center of everything that we do, and we strive to make a positive and meaningful difference in their lives, in your lives. And so today and every day, we're proud to be here with you virtually and in real life to raise awareness, to take action, and to continue to fight to end epilepsy. And with that, I'd like to introduce and first of all, thank very much our special epilepsy experts, Dr. Katani and Dr. Eisenshank. Dr. Katani is a board certified in both neurology and epilepsy by the American Board of Psychiatry and Neurology, practicing at Advent Health Tampa. She is a member of the Academy of Neurology and a member of the American Epilepsy Society. She is currently an active board member, thank you for that, on Epilepsy Florida. She focuses much of her efforts on improving the patient experience and providing care for underserved populations. Dr. Eisenshank is an associate professor of neurology in the University of Florida's Department of Neurology. He attended the University of Florida as an undergraduate in the Medical Honors Program and graduated from the University of Florida College of Medicine in 1993. He then completed his residency and fellowship in clinical neurophysiology and epilepsy and sleep medicine at the University of Florida and has been on faculty at UF Health since 1998. He is one of only a few physicians to be nationally board certified in clinical neurophysiology and sleep medicine. So enjoy this tea time. And again, thank you for the opportunity to sponsor this evening.
Thank you so much, Tanya. And now I'll introduce to you Dr. Katani.
Hello, everybody. Thank you all for coming to our monthly special event of Tea Time. We are here to serve you, to help you, and let you know that you're not alone and we're here for you. And there is hope, and we're here together. And thank you so much for the kind introduction, Tanya. And thank you so much for Dr. Eisenship for coming today and being our guest speaker.
Thank you. And Dr. Eisenschenk, the floor is yours.
Okay, all right. So let me see if I can get my screen to share. If everybody can everybody see sort of the PowerPoint?
Yes.
Okay, good. All right, so again, I have no problem with anybody stopping me any point through here. I don't know if I'll see the hand raised, but if any questions come up, again, please don't hesitate. And I already seen one question that'll be very important, the first question asked, so we'll definitely get to that. So being for the past 20 years, I've known Tanya Talton. I mean, you will not find a better advocate for for the patients. So that's sort of on the side. What we're going to try to do tonight is have you better understand driving in general and what's necessary to drive. So we have a very large driving simulation program at the University of Florida. And where I got interested in determining driving in neurological conditions is trying to find out which patients and which kind of conditions are safer to drive, because there's very little information and data out there to help our patients figure out what kind of circumstances are better for them. So this is a video showing a catastrophic accident. So this is a person on the turnpike up in New Jersey, and you can see that they're attempting to drive. This person had a known seizure disorder. And you can see the police officer was following this individual. So when we saw this video years ago, back in 2007, we were interested in trying to determine, okay, the report was this individual drove for several miles before having an accident. And it's most likely going to be associated with a seizure, but what allowed that individual to maintain driving capacity for that longer period of time before, unfortunately, they had a catastrophic accident. So we look at different parts of the brain. Again, try to sort of minimize this stuff. I mean, don't get too tied up in some of this neuroscience stuff to begin with. But whereas important is that you need these sort of deep brain structures called the thalamus, and you need your brainstem to keep you awake. So the worst kind of conditions that we see are people who get very sleepy. The one thing we can tell you try not to do if you're out driving is definitely avoid driving between 2 to 4 a.m. By far, there's a marked increase in accidents because there's a variation in your sleepiness patterns that you're most sleepy between 2 to 3 p.m. and again between 2 to 4 a.m. And so we see very many catastrophic accidents coming off I-75 for us up here in Gainesville because of the fact that people are sort of falling asleep while they're driving. And that can lead to a very catastrophic accident also. Now, obviously, you need the back part of your brain, and that's your visual area. So obviously, if you lose more than 30% of your peripheral vision, particularly on the left, because then you can't see your side rear view mirror, you're prohibited from driving, just from that standpoint alone. The front part of your brain, this is the motor area right here in the back part of the frontal lobes. And that's obviously you need that for your motor activity, to steer the steering wheel, to push on the gas pedal. But what we're also very interested in is this far front part of the brain. And the reason for that is it sort of helps plan out what you're doing and why you're doing things. So if you want to go to the grocery store, it helps you process that information to be able to make it to that direction, to that grocery store that you want to go to, and then obviously buy the things that you want to buy. Without this frontal lobe, there's no way to visual spatially get to that location. So where we see this as a problem is patients with Alzheimer's disease. This area starts degenerating in Alzheimer's patients, and they don't have the ability to sort of plan out and decide where they want to go. And that's why you see some of these silver alerts throughout the state. These individuals will get on the highway and just start driving. And they're not able to process that information. So again, we're not just looking at epilepsy. That's one of my main focuses because it's my main interest. But we're trying to figure out from a lot of different neurological conditions, where are patients prone to getting into severe accidents, in particular if they have injury to this sort of parts of their brain, or if they have a situation where that part of the brain is not functioning well. Your parietal lobes in the back part of your brain, that's more for your sensation. You need to know how hard to push down a gas pedal. These are patients who have had strokes back in this area, sometimes a brain tumor that will prohibit them from being able to understand how much pressure you need to put down a gas pedal, how much you need to turn the steering wheel. And those are all things that can affect your ability to drive. Cerebellum's balanced. I'll skip through that one. Now, the structure that's most important for our epilepsy patients is this green area. That's called the temporal lobe. So 70% of all your seizures are going to come from this temporal lobe. Now, fortunately for driving circumstances, your temporal lobe is predominantly involved in sort of emotion, very anterior here, called the amygdala. And then deep in that area is the hippocampus. And that area is very, very important for your short-term memory. And it makes sense that that is the location where more than half of the focal seizures come from. Your hippocampus has to be firing off constantly. And so the way I explain it to my patients, it's like the engine for your car. It's sort of just idling there. But when it needs to put down a short-term memory, it speeds itself up and puts down that short-term memory so that you can retain that for long-term memory. And so that structure is going to be very, very active. It needs to determine what's important, what's not important. So it's constantly being very, very active. And because of that, it makes it a lot more likely that you can get in situations where it can be too excitable, or maybe not enough inhibiting activity, but more likely getting too excitable. And what happens then, it sort of fires off at a rate too fast. And because of that, it can generate a seizure. And that's where the majority of our patients who have seizures, that's the area where it comes from. And it's not as important if you're driving. I mean, of course, if you're driving to work and you see the guy on the side of the street at Chick-fil-A wearing the cow uniform, obviously you want to remember that, but it's not absolutely necessary to remember those things. But obviously you don't need that to be able to drive in regards to your short-term memory. So the theory was that if you have seizures that just stayed in this location here, you may be able to drive sufficiently. It's when they spread outside this area is when we start seeing patients have more consequences from their seizure disorders. And so what we're doing is different ways to look at this. We're obviously looking at the EEG. This is a fancy way of looking at how your brain connects using MRI. And so we're looking at motor cortex, the front part of your brain, the visual cortex, and all those kind of things to, again, figure out if you have damage to any of these kind of structures, are you going to be at a risk for hurting yourself or hurting somebody else while driving? Or if you don't have injury to that, will it be safer for you to allow to be able to drive? Again, this is sort of a holy grail, trying to find these more objective tests. But it's going to be important, I think, in the next 20, 30 years. After that, I think self-driving cars are going to put me out of business for my research. All right, just go to one page. All right, so when you're having a seizure, what you see is this increase in excitability. So that's sort of what the video on the bottom sort of describes. Hope you all can see that. And that area can actually generate a short circuit in that location. Again, if it's in the temporal lobes, it's going to knock out your ability to understand and comprehend things. If it spreads beyond that to like your motor areas, that's when you start seeing patients who have the generalized tonic-clonic seizures. The lifetime prevalence of having a seizure is very high. It's about 10%. And it can affect anybody at any time. So if anyone thinks that they're not susceptible to having a seizure at some time of their life, they're greatly mistaken. Now, only about 2 or 3% of people will have recurrent seizures, but our Chief Justice of the Supreme Court, Chief Justice Roberts, has had 2 seizures in public. You can Google that and find those that kind of information. It's not from personal, it's not a HIPAA issue. So it just shows you that you can be at any walk of life and unfortunately have a situation where your brain sort of just short circuits and causes you to go into that seizure. So this is not an uncommon thing. The unfortunate thing is that society still has not realized how debilitating it is. And what I mean by that is that there's a lot of research that shows that at least 99% of the time patients with epilepsy and overall, they're doing perfectly fine. It's that 1% of the time when they have the seizure activity that ruins the other 99% of their lives. And so there's a lot of issues with depression, anxiety, frustration that sort of develop from that. Things that people just don't realize how debilitating these things are. And then if you can put on medications, how much these medications may affect you also. So it's a constant struggle that we have with the disability issues at the VA. I have constantly working with the administration, and luckily we're one of the epilepsy centers of excellence, so we have a little bit more pull to help our veterans in regards to these issues, because it's a disease process that can be very, very disabling to a lot of individuals, particularly because of driving. All right, so what kind of seizures are more risky? I mean, obviously, if you have a seizure where you used to have motor activity, you start jerking, you have activity where you can't see well, obviously those are going to be situations in which you're going to have an accident. Now, occipital seizures in the back of the brain are very rare, but motor seizures are not that uncommon to see. Uh, there was a theory for a while that if you had aura, which means you had a warning before the seizure activity, it could be protective. We're seeing some data more recently that it may not. So what I always tell patients is don't try to beat your aura. And what that means is if you have your complex partial seizures where you lose awareness controlled and the grand mal seizures are controlled, but you still have auras, which is not uncommon, if you're in a situation where it could be a danger to you or somebody else, driving, cooking, swimming, get yourself out of that dangerous situation, because it only takes a few seconds when we're watching our patients and our epilepsy monitoring units go from a situation where they're aware of what's going on to a situation where they can't. And you have no control of it once you lose that awareness. So that individual who was driving on the New Jersey Turnpike, they were able to continue to drive because that seizure most likely just affected the temporal lobes. But if it spreads beyond that area, then it inhibits the ability to sort of process the information of exactly how much speed you must need to have, what uh, your lane maintenance is. All those kind of things help. Now, again, where I think things have improved dramatically is actually the motor vehicle industry has done a great job at increasing or expanding the ability for your cars to actually keep you safe. So those kind of things will definitely help. But if you're accelerating in a situation where it's a 45-mile-an-hour zone, and that's what happens with a lot of patients who are having the seizures, they tend to accelerate their cars, you're still not going to be able to brake in time to stop something, particularly if there's somebody, unfortunately, walking across the street.
This patient has rather subtle signs
So
of
this
a
will be a
complex
patient who has a
partial
complex
seizure,
partial
to the
seizure and
extent
show
that
you
a
the
staff
subtleness of
member
this.
interviewing him does not initially realize that the patient is experiencing a seizure.
They are. It's like a box. You want to turn the page, and I want you to put these chips.
Initially, he stares blankly and begins rubbing his eyes, then exhibits other automatisms such as a fanning motion with his right arm. Initially, bursts of spike and slow wave activity are seen in both hemispheres. However, no clinical changes are seen. Later, rhythmic activity builds in the left temporal region, and the patient begins smacking his lips together.
So what you're seeing in this individual is he's having a temporal lobe complex partial seizure. Again, these are very, very subtle. After these seizures, because it affects your short-term memory, he won't remember these events. So we'll go in after a patient has a seizure like this and talk to them, and they may hit a button to show that they are having an aura. So they know the seizure is coming on, but after the seizure is over with, they will not recall that. So that's where it gets very, very difficult, I know, for a lot of our patients to be able to sort of talk about and describe what's going on. And it's very important also to have our patients bring somebody who's a family member, caregiver, spouse, friend, to help describe what they're seeing at their home, because these can be so subtle that they can actually be missed sometimes. And it's very common that we see patients, like for the very first time, who come to our clinic who say that they think their seizures are under control, but really what's under control are the grand mal seizures. And you start talking to them, and they start talking about these episodes where if the patient's by themselves, it's tough. If they have a caregiver with them, they'll say, yeah, I sometimes see them staring off for 2 or 3 minutes, and they seem a little bit confused afterwards. I mean, the other thing I often use is how many times have people had accidents. So, I mean, a few months ago, I saw a patient who the question was whether or not she was having heart-related syncope versus seizures. And my question to every patient is, have you had any accidents either around the house, where she did not, or have you had any car accidents? And she had happened to have 6 car accidents in the last 3 years, of which 3 cars were completely totaled. So in my book, that's somebody who's more likely than not having a seizure disorder. And sure enough, we put her on medications, and she's no longer having any of those events anymore after several months of being on the meds. So again, these can be very, very subtle. The difference would be is, can you maintain enough awareness while you're in one of these partial seizures so that at least you can get yourself into a safe situation so that you don't get into a severe accident where you hurt yourself or hurt somebody else. And again, that's one of the reasons why I really started advocating for this kind of stuff. It's for our patients, at least I would say 2 of my patients a year have severe accidents. On average, I would say at least one patient of mine a year has had accidents in which somebody has gotten hurt enough or has died, unfortunately. So some of the stuff we're trying to do too is make sure that everybody understands that we want to make sure that everybody's safe in these kind of situations, but especially our patients, making sure that they're safe. All right, so the unfortunate thing I think with society is that people don't realize how dangerous having driving is. So this is an individual, it's not seizure related. And so more patients, hello, sorry, a little place here. So more patients actually have accidents from other conditions, particularly sleep deprivation. People who work more than 60 hours a week, people who work night shifts, increase their risk for having significant accidents by 2 to 5-fold constantly. And that's something that's unfortunate, I think, that we don't talk to our patients enough about. That's why I can tell you, between 2 to 4 a.m., you definitely don't want to be on the road. You also have to be very careful between 7:30 a.m. and 8:30 to 9 a.m. And the reason for that, there's a lot of shift workers now. 20, 30 years ago, you didn't see that. A lot of groups, hospitals aren't by themselves, have shift workers. And those people get off of work around 7:30, and they're driving home, and you see a much higher risk for having accidents around that time. So again, if you're sleep deprived, the best thing you can do is either take a nap, or if you have to push through it, caffeine will help you out. Best thing to do is don't drive during that time period. But epilepsy patients have been stigmatized, unfortunately. They have a lower risk than people who have sleep deprivation. But because they have a condition, and if you're a patient, you really understand this, they have been, people have been stigmatized with epilepsy for so long that the restrictions, I think, are too strong to some extent. Where it becomes challenging is, make sure I don't skip too many pages, is trying to figure out and working with the national government and the state regulations. I've worked with the state DMV quite a bit over the last couple decades, and trying to determine who's safe and who's not. The main studies that you'll see out there are studies where Department of Motor Vehicles have changed their driving regulations. There's very few groups that have actually tried to do what we do, which we'll get to, is working with simulators to try to determine who's safe and who's not safe. And so it's gotten to be a little bit of a roadblock at this time. And that's why we've expanded beyond just epilepsy, looking at stroke and multiple sclerosis and Alzheimer's, and trying to figure out, in regards to the brain itself, what kind of areas are necessary to maintain good driving capacities. And then getting people to realize that people with epilepsy have been unfortunately stigmatized, that they are at risk for having accidents, but they may not be at the highest risk. So your people who are driving because they're sleep deprived, or people who are intoxicated, obviously, CBD, we're seeing a higher increase of accidents related to some extent with CBD. You have to be very, very understanding, but it's been a big, big battle over the years. The reason why it's important, again, is the risk of injury. And if you look at when cars were first developed, it was actually started in the United Kingdom in regards to restrictions. We can go through all that kind of stuff if you have any questions about it. But it was mainly because they were concerned that people were going to have accidents and hurt pedestrians more than hurt themselves. So it was a way to help try to minimize the amount of accidents that could be related to people who didn't have cars initially. Is how this all started. Now, the thing you have to be careful about is it's not your physician who determines who can drive and who cannot drive. And that is a very tricky situation. And what I mean by that is that patients notoriously will come to me and ask me, can I drive? And I make sure that they understand it. It's, again, not me making that final decision. It's actually the Department of Vehicles for whichever state that you're in. So as a patient with a seizure disorder, it is your responsibility to contact your state DMV and notify them that you have had a seizure, or if you have recurrent seizure moving from another state. And they are the ones who determine whether or not you can drive. In this state, if you've gone through the process, you would go to your DMV. They would send you and mail you a form that you then pass on to your physician. And it's a form that covers a lot of different medical issues, seizures being one of them. We fill that form out and fax and mail it back to the Department of Motor Vehicles. And there's a medical advisory board that actually makes that final decision of whether or not they think it's safe for you to drive. It's not, the physician can, and I advocate for my patients typically, if they're under certain guidelines, but it's not the physician. It's really the DMV that will make that final decision. Again, patient's responsibility. That said, I don't fire my patients. I don't kick them out of my clinic if they don't report themselves. And it's estimated that anywhere between 50 to 75% of patients in this state do not report themselves. That is where it gets tricky. And the reason why it gets tricky is that the person themselves is actually putting themselves at liability. If you don't contact the state that you have a seizure disorder or any medical condition that might affect your driving capacity, I do a lot of medical legal expert stuff in these kind of regards. You're putting yourself a little bit at risk, unfortunately. I don't think that's fair, but the lawyers will be very good at trying to point that out, that it's there. And if you read your doctor's notes, typically, definitely if you read my notes, it will state that the patient was informed of state of Florida regulations for driving with seizures and that they were instructed to contact the DMV. Now, if you have a new onset seizure disorder, I typically tell my patients, do not contact anybody in the first 6 months. Do not drive, but do not contact anybody, because if you go to the Department of Motor Vehicles and walk up to the counter, nowadays you have to have an appointment, obviously, but you have a 50-50 chance that the person behind the desk doesn't really understand the regulations, and they may on site just revoke your license. And that's a huge hassle. Once your license is revoked, to get it back, to get your insurance back. What I tell my patients is that you can't drive for 6 months, and in 6 months, then I give them a letter saying the patient's been under my care for 6 months, and they're informed to contact the Florida DMV to ask regarding driving privileges, and then go through the process at that point. Because in this state, it's typically a 6-month waiting period after having a seizure before you can drive again. But again, it's not uncommon. If you're going to epilepsy clinic, be very careful because if your physician is seeing multiple patients for epilepsy that day, I would estimate in a half-day clinic of 8 patients, probably 2 or 3 of my patients have driven to their appointments, and they will say that there's somebody waiting for them in the garage or somewhere else. Especially with COVID nowadays, it gives them an excuse that nobody else is with them. And a couple of my patients have actually had accidents on the way home. And obviously then they get their licenses revoked in those kind of situations. It depends on where you live. This varies considerably from state to state and country to country. So on the bottom is the European. The European Union is actually much, much more prohibitive. With a new onset seizure, it's 6 months. With recurrent seizures, it's actually 12 months. And some of our research actually suggests they're probably closer to what's probably the right thing to do. That said, we have still advocated for our patients in this state to be able to drive after 6 months. There's some data that suggests that there's 6 states now that are down to 3 months. Arizona, the Dakotas, Kentucky, New Jersey, and I've gone blank on the last one. There's a slide that used to be in here that I took out. 3 months is pretty close. I mean, the reason for that is that a lot of our patients will have seizure-free periods for 3 to 6 months, and then have breakthroughs right around that time. So again, in those patients, luckily, a lot of times they do have auras. So they are a little bit less likely, because we are adamant, you get an aura, you pull over immediately. You wait for that situation, you call somebody to come get you. If you're confused, disoriented, don't try to race this thing to get home, because you will not win that race whatsoever. If you're not, and that is if you're following with a physician and the physician signs off. If you're not following with a physician in this state, the state of Florida, it's actually 2 years of no driving. If you're not following with a physician, it's 6 months if following with a physician and the state of Florida Department of Vehicles Medical Advisory Board authorizes you to drive after 6 months. Again, personal liability gets there. Several years, actually probably 15, 20 years ago, showing how old I am, there was actually a law that was attempted to be passed in the state because unfortunately in the St. Pete area, an older man in his 90s who had Alzheimer's had an accident and killed a homeless man. I won't go into all the details about that, but one of the local politicians, state representatives, tried to pass a law that stated everybody with seizures, everybody with sleep disorders, and everybody with dementia had to be reported immediately to the Department of Vehicles. I fought that for about 18 months and did some leeway, but it actually got to the final committee. Fortunately, it's not what you know, it's who you know. When I got to that last committee, the chairman of that committee happened to be from the Orlando area. And I have he was a very great man who just passed away 2 weeks ago, Leonard Williams, who runs the Dench Foundation and the Budweiser distributorship down there. I called him up and in 24 hours, the bill was gone. So the reason we didn't want that is that we don't want our patients coming back to us worrying that we're going to turn them in immediately to the state about driving. We want our patients coming back to us so we can help them. And there is some data to suggest that if patients are in a mandatory reporting state, they tend not to come back to the physicians and they tend not to tell them that they're having seizures if they are. So fortunately that got blocked because it was going to be a very debilitating thing. And again, tremendous respect for Leonard Williams and everything he's done for the Epilepsy Foundation, everybody else. And unfortunately, he passed away 2 weeks ago. Commercial driver's license, extremely restrictive. This is the same thing for the FAA. For pilots, I see a lot of pilots where we have to go through these kind of stipulations. If you want a commercial driver's license, you have to be seizure-free off of your medications for 10 years before you can get a commercial driver's license. And because that's interstate transport, that's not going to change. That is extremely restrictive. That said, it's hard to do interstate regulations, and the national government and Department of Transportation is not going to change that rule. And with good reason. I mean, you do not want somebody with a semi-truck having a seizure disorder, or even if they're controlled, if they happen to miss a dose of medication, which is probably one of the more common reasons why people have an accident, that is could be a very disastrous situation for those individuals. So we've done some research into this. I mean, the things that are not predictive, being in a mandatory reporting state was actually not being predictive. That's actually going to reduce the number of accidents. The short seizure-free intervals, which means about 3 months. So if you move to Arizona and Dakotas, Kentucky, New Jersey, in those areas, I think it's New Jersey. Actually, I think it's New Hampshire. If you're seizure-free for 3 months, you have the right to drive. Just be very careful in those kind of situations. Where it has been shown to be, if you're 6 to 12 months out, very low risk for having seizures, unless you miss your medications or if you have an infection. If you've had epilepsy surgery done, which means we've taken out the main area where the seizure activity comes from, much lower risk for having accidents. The few prior non-seizure related accidents is a little bit of a confounder, and what that means is that individuals who've had accidents prior to seeing us and being diagnosed with seizures probably were seizure related. They can't be proven as seizure related because unless the Florida traffic report or a physician documents the patient had a seizure related to the crash, is considered a non-seizure related crash overall. And patients who are following their drug levels closely have a much lower risk for having recurrent accidents. This is our simulator. It's a forward focus that was cut down. And the individual on the right side is going to have a partial seizure. So halfway through this video, they actually start into their partial seizure. And you can see that they're wavering a little bit in regards to their driving abilities. And that's sort of similar to what we saw with that accident from New Jersey. And so at this point, when we're watching the EEG, the seizure activity was very localized to the temporal lobes, had not spread. But it started to get stronger and stronger on the EEG. And as you'll see, once it gets stronger and stronger, this individual loses his ability to maintain his road. And unfortunately, in this case, his foot fell off the gas pedal, but he gets right into a tree. And that would have ended up being a catastrophic accident for that individual, unfortunately. I think the rest of these are just more questions. These are more slides just to talk about. If anybody had any questions, I could use this as sort of a reference slide. Anybody, I guess, have any questions from the chat?
There was a question at the beginning from Jackson B.
Okay.
Jackson, do you want to ask your question? Do you want to talk to the doctor? You can unmute yourself.
If not, I could just answer it. If he doesn't want to
Okay.
talk, that's fine.
Sure.
I think I just lost my chat. Where's my chat? There was a question about changing medications.
Yes. How do you transition amongst multiple medications if you want to come off of one? If you want to come off of one in regards to driving?
Yeah. So that actually is the state of Florida has actually done a very good job. Even before I got here in 1982, they actually came up with this 7 stipulations for driving, and I think it's the 5th stipulation. It was a slide and I took it out. The 5th stipulation for driving states that if you taper off a medication, that you cannot drive during that taper off the medication, plus an additional 3 months. And again, that was all developed on some research that showed that when patients transition off medications, their highest risk is actually within the first 2 or 3 weeks after stopping any medication. And the reason for that is that your brain is used to that drug being there. So it's not uncommon for a patient to have a single seizure or so right afterwards. But statistically, the rate stayed high for about 3 months after stopping a medication. So I've had extensive discussions years ago with the Department of Motor Vehicles about this. And you can blame me a little bit on this one because it was a consensus in that if you're on multiple medications, you don't know whether or not it's that combination of medications that's making you better. What often happens is that you're on a drug, let's say Dilantin, they decide to put you on, not gonna put you on Epidiolex, let's say on Keppra or Vimpat, sorry, Tanya, and you become seizure free. And then the idea most of the time would be that the doctor would want to taper you off. So the best time to do that taper is when you first get started put on a medication. Because I can tell you, I've seen a ton of patients back who want to come off one of their seizure meds and they've been seizure free for years, sometimes 10 or 20 years. But if you're seizure free on Dilantin plus Keppra for more than 6 months to a couple years, I cannot tell you how much the Dilantin is helping. So if you want to come off the Dilantin, you have to stop driving. And so let's say you're on 300 milligrams of Dilantin. I'll tell you stop by 100 milligrams every 2 weeks. So you do 200 milligrams for 2 weeks, then 100 milligrams for 2 weeks. So that's 1 month of time that you can't drive, plus 3 more months that you would not be able to drive again. So whenever a doctor is trying to make a transition on your medications, the best time to talk to them about those issues is once you get on a good stable dose of the new medication. Talk to them about, do you need to be on this other medication lifelong? Because if you're doing really well for those first 3 to 6 months, you're not driving anyway, because obviously if they put you on a new drug, it's because the seizures are still occurring. That's the time you want to come off of it. Because I have patients who are on drugs that, like Dilantin, that cause a lot of drug interactions, a lot of side effects for 20 years because they drive. And they absolutely cannot stop that medication, even though a second drug is really what's probably keeping them seizure free. So that's the time. So if you want to come off a med, you can't drive during that taper, plus an additional 3 months off that medication, no matter how long you've been seizure free.
Okay, thank you. Jackson B also says they're a former patient, that you are awesome, you've changed their lives, and they named their son after you.
I think I know who that
So
is.
nice.
Sorry, I feel bad for their son, but that's okay.
We
Thanks,
have,
Jackson. I think I know who you are.
someone has their hand raised. It just says iPhone. I'm not sure your name, but you can unmute yourself and ask a question.
Okay, that's me. My name is Mindy. Thank you this is my first time joining, so thank you for doing Team Time. My 15-year-old daughter was diagnosed with epilepsy in January. And so she has her learner's permit, but since the seizure, she's not been driving. Her doctor said 6 months without driving for her being seizure free. So my question is, I don't know how that works. She actually 6 months puts her at her birthday if we stay seizure free this whole time. And I didn't know, do I report something now to the DMV? I'm just holding her permit and she's not driving, or do I wait until those 6 months go by and then go in and explain the situation with the form or start with the doctor? I wasn't quite sure the process for all of that.
So, I mean, you could go in immediately, but like I mentioned before, if you go in immediately, it's unfortunate. The person behind the desk a lot of times doesn't know the regulations. And what should happen is that it should be passed on to the Florida DMV. And the Florida DMV would then make the determination about driving. My experience has been that you have a 50-50 chance that the person behind the desk at the DMV will just basically take your license and revoke it. And that is a huge hassle. So because she can't drive for 6 months, it does delay things a few more weeks. I usually recommend stay seizure free for 6 months and then contact the Florida DMV stating that she has a seizure disorder, but she's under the care of a physician. She's been seizure free for 6 months, and then they should not revoke your license. I still have some cases where people have had their license revoked, but that's pretty rare to see. So I would wait 6 months and then talk to your physician. As a physician, I stand like I have a templated thing. I hand my patients a form letter so they can take it to the DMV. It won't help you that much, but it'll keep the person behind the desk saying, look, you have somebody behind you who's supporting you to go ahead and get that license back or to be able to maintain your license at that point. And then what would happen is that the DMV would contact you and send you a form, and that form would be turned over to your physician, and the section on seizures would be filled out, which it says, one, how often do you see the patient? When was the last time they had a seizure? Are they on medications, and are they seizure free on medication? Is she taking medication right now?
Yes, Keppra. So basically, so if she has a second seizure, which I pray to God she never has another, but if she has a second one, that 6-month clock restarts. Is that how that works? So then, so really it's waiting for 6 months of being seizure free to go to the DMV with the form that is on their website and starting the conversation then?
Well, I mean, you can go to their website and call them, and they should send you a form, because that form will have her driver's license on it, number. It used to be in our physician offices, they would allow us to have those forms. But what happened is, and they got concerned about, because I worked with them, is that people were basically stealing the forms or making their own forms up and then turning them in on their own and forging the physician's signatures. So the original form has to come from the DMV because it will have her driver's license number on there.
Okay, I get it now. So we go there after 6 months to the DMV to get that form.
Yeah,
and then
you can go to their website too and contact them by phone.
Okay.
And that's probably easier because this way they're less likely when you call them by phone to sit there and obviously talk about revoking it, because they understand the rules better. And then they'll send you a form that you can pass on to your physician.
Okay. Thank you.
Sure.
Thank you. Does anyone else have a question at this moment? Yes. You can unmute yourself, Sean.
Sure. Okay. At present, I'm 51 years of age. And at the age of 11, I started having seizures. Along life's way, well, initially I started having grand mal seizures. And over the years, thank God, whereas initially I got a seizure, I would take like about 2 weeks to 3 weeks to come back to my normal self, memory and that kind of thing. Over the years, it has come down to like 2 hours, an hour, you know.
Okay. Good. Bad that you have a seizure, but good it's getting less severe.
Yeah, what would normally happen is I would have you would start getting the aura. You know, you would start getting this funny taste in your mouth. Then I saw the aura that would last for like about 30 seconds. Then I would need to rest because while I would know the people around me, I wouldn't be able to put ideas together clearly. So I need to rest. But one of my concerns is this. I noticed like for about maybe say within the last year, this is the best way I can describe it. I have what I call a visual disconnectivity. That means, so for instance, my eyes, I'm seeing you right now, but sometimes it's almost as if my eyes, they do not work together. I am, you understand what I'm saying?
Oh, yes.
I
Do
am
you
not,
ever feel like you're out of your body looking at something else also? Or does things look bigger and smaller?
no, when I was taking Dilantin, you understand?
Oh,
And I had a dose. That is how it seemed. Things look bigger and smaller, kind of thing. But now I am on carbamazepine and Divalporex.
okay.
So, but it's almost as my eyes. There's a fish. One moves that direction and the other one moves that direction. Is almost as if I don't see things together with my eyes.
Have they ever told you that your seizures might be coming from like your posterior temporal region, or do they know where the seizures are coming from?
I am not too sure. I can't even remember. I can't remember. You
Okay.
know?
I mean, EEG sometimes will help you out. Sometimes the MRIs will help you out to figure out. I mean, it's going to be. I mean, the reason they're probably better controlled is were they worse controlled when you were on Dilantin?
Well, when I was on Dilantin, at that time I was getting the grand mal seizures kind of thing, you know.
Yeah. So the problem with Dilantin is that if you try to dissolve a pill of Dilantin in water, it doesn't. You have to put in ethylene glycol, which essentially is antifreeze. So the levels for Dilantin fluctuate tremendously. So it wasn't uncommon for our patients to be blamed that they're non-compliant on their medications if they're taking Dilantin, and it's really because the drug is just poorly absorbed into your system. So if those levels fluctuate a lot, it would make it that you're having much more severe seizures. The carbamazepine and the divalproic acid are much more stable medications overall. And it's probably because they got you on a better regimen is why the seizures are less severe. The visual things, I mean, it's you're while you're having a seizure, or after you're having a seizure, the excitatory activity of that part of the brain is short circuiting. What's happening though is if you look at the brain tissue around that, it's inhibiting things from spreading. So it's trying to keep you from going into a grand mal seizure. And because of that, that's sort of that while we're looking at these connectivity issues, it decreases your brain's ability to connect to different locations. If it slows down those connections, your brain can't process information as well. I mean, essentially, hopefully everybody here hasn't been too drunk, but if you have a few drinks, it's sort of the same kind of mentality. Your brain's slowing down, you just can't process the information, especially if you get a six packing into you or something like that. So those are the things that are most likely what's occurring when you're having those kind of unusual visual auras overall.
Another thing I'd like to know is how it relates to sleep. What do you recommend? How should I try and sleep? What hours is best?
So one of my secondary specialties is sleep. I mean, so the best way to determine how many hours of sleep an individual needs, and good luck with this one, is that you would fall asleep without any type of sedatives, nothing over the counter, no Benadryl, no Lunesta, no Ambien, and you would wake up without an alarm clock. That's the duration of sleep for any individual out there. Now, that's hard to really determine because society doesn't let you do that anymore. But most people need, if you look at the statistics, between 7.5 to 8.5 hours. And with a patient with epilepsy, we're trying to advocate for that. The reason for that is that if you're sleep deprived, you are far more likely to have a breakthrough seizure. If you have sleep apnea and you have fragmented sleep while you're sleeping, much more likely to have a seizure. And the seizures that occur during sleep, because your brain actually synchronizes better while you're sleeping, it actually is more likely that you'll go into a grand mal seizure. And the scary thing about that is that puts you at higher risk when you're sleeping of a condition called SUDEP, sudden death in epilepsy, where your heart and your breathing can just stop during a seizure. So you need to try to protect your sleep at all costs, if possible, to reduce your risk for having recurrent seizures. But for an individual person, I tell you, shoot for 7.5 to 8 hours as a sort of a standard. But if you can figure it out yourself, it'd be, if you could fall asleep and then wake up, and those are the standard times you do without any sedatives, without any alarm clocks, that's the amount of sleep that you would need individually.
All right. And also, the last question, the carbamazepine and the Valparex, prior to that, I was taking it's a Tegretol and something else England. And I noticed when I switched to the Valparex and the carbamazepine here in the United States, I got my memory. It took me it took me a while to remember things, and from time to time I still find myself wondering, you know.
Yeah. Well, they switch it to the generics. So usually what I tell people to do would be, if you're on a brand name medication, and the one that's going to be most concerning in the next couple of years is Vimpat. We don't usually follow levels for Vimpat, but when you switch from a brand name to a generic, I will get levels. And so I would have got level of the Tegretol level that you had, carbamazepine, and the valproic acid level. And then once you switch over to the generic, I would repeat those levels within 2 to 4 weeks and make sure that those levels aren't changing very much, because there'll be a bigger fluctuation among the generics out there.
Okay, thanks.
Great question, Sean. Thank you. And Jackie has her hand up. Jackie, you can unmute yourself.
Can you hear me?
Yes.
Okay. Should I do video? Does it matter? Start video. Okay. So I have a 15-year-old daughter who is a sophomore in high school, and she has partial seizures since she was 8 years old. And I'm wondering, she has her learner's permit right now, but most of her seizures are nocturnal. I would say like 98% of them happen in the middle of the night. Would she still be eligible to get her license in June?
So there's actually one of the 7 stipulations, and this is one I fought with the state to make sure they maintain. If she only had nocturnal seizures, she could actually drive now, as long as they're only nocturnal seizures. Now, that said, in the last couple of years, new individuals on the DMV Medical Advisory Board have been much more difficult to deal with. One of my patients who had only nocturnal seizures, he was actually seizure-free for more than 6 months. They wouldn't let him drive for 2 years. And so I had to write a letter that I had to rescind a little bit about if there's eclipse. I put a whole bunch of stuff. I was so ticked at him about that.
Yeah.
But if she only has nocturnal seizures, now if she has daytime and nocturnal seizures, then that doesn't count.
Okay.
So it would be 6 months from her last daytime seizure typically.
Daytime. Okay.
If you can convince your physician to sort of sign off on that. Sometimes the physicians are a little more reluctant if they have both to sign off on that. So what I do, and there's a comment section, I would say, look, the last daytime seizure she had was this date more than 6 months ago.
Right.
She has intermittent nocturnal seizures only while she is sleeping.
Mm-hmm.
And
They're
while you're sleeping,
right as she's waking up in the morning.
Does she have a primary generalized epilepsy, did they say?
No, just the focal motor seizures. Yeah. It's just the right arm and the right leg. And
Does she have what's called benign Orlandic epilepsy?
No, it's never been given like a real syndrome or anything. It's really bizarre.
Okay.
Frustrating.
Yeah, I mean, you near a major city anywhere?
We go down to Miami Children's. Yeah.
The Shoshone or somebody else down there?
We go to Dr. Resnick.
Okay.
Yeah, we're in Jupiter right now. So.
You're in a good place.
Yeah, it's frustrating condition. So my heart goes out to everybody on the Zoom because it's tough, but yeah.
So how often does she have daytime seizures? And then
almost never. I mean, almost never.
So how often does she have them when she first wakes up? Is she awake when she has them or before she wakes up?
No, it's before she wakes up.
Okay. So how often is she having those?
I'd say 1 every 2 weeks.
And no way to predict when they're going to happen?
No.
Okay. Not stress from school and stuff like that?
Well, stress and menstrual cycle definitely both play a factor.
Yeah. So menstrual cycle, I mean, one option would be to go up on her anticonvulsants for a few days before the menstrual. If you know it's a certain date, that's very good. You can adjust some of in her case, I would only adjust the bedtime doses.
Okay, that's good to know.
And then Alternatively, I do give patients things like clonazepam or lorazepam
Mhm.
during that time period also that has helped reduce their seizure frequency.
Great.
What's she taking for medication?
Oxcarbazepine, Oxteller, and Vimpat.
Okay. So she's like an Oxteller. Okay.
Yeah,
The problem with that one, it's a very slow acting agent. It's a once a day dose for her.
it's once a day at night.
I'm sorry. And you said Vimpat also?
And Vimpat twice a day. Yeah.
So she could go up on her nighttime dose of Vimpat and see if that helps.
Okay.
So
That's
what she's having is called catamenial seizure with a menstrual cycle. But if it's predictable, I usually make some fluctuations on their dosing right around the time of them. If they can predict, I'd go up 2 or 3 days before the estimated time, just in case there's variation, and then
Right.
run it for another 3 or 4 days afterwards. So like a week a month, I go up on their dose, just in her case at bedtime. And this
okay.
patient wouldn't have as many side effects during the daytime. And
Thank
hopefully
you.
Dr. Resnick won't say I'm an idiot. And
No, no.
else.
Thank you so much.
I know who he is. He knows who I am.
Thanks, Jackie. I wish you and your daughter the best. We have a question from Martin. He's asking, do you believe that epilepsy can be caused by vaccines?
For the most part, no. I mean, I think that there's a rare case where I've had patients. I know of a severe case from somebody got transferred all the way from Saudi Arabia to see me in UF because they got a vaccine so they could travel, a young child, for meningitis, and went into status epilepticus, uncontrolled seizures. That is extremely rare to see something like that. And those patients are, they sort of come up with the COVID vaccination stuff. Those are patients where you just can't predict. It's very, very rare that you would see somebody who has a predisposition to one of these autoimmune, the body attacks itself reactions to anything else. The way I look at things is that if you are concerned about that, look at everything else. Is that individual prone to having allergic reactions to other foods, other drugs? And if that's the case, then I tell my patients, we've told some of our patients not to get the COVID vaccine in those kind of situations. Most of our patients were advocating get the COVID vaccine. I can tell you, I've seen enough people in the ICU in their 20s and 30s that the risk for the COVID vaccination is minimal compared to getting COVID.
Right.
And if you do want to get the vaccine, what we're also telling our patients to do is to consider pre-medicating with Tylenol. And then if you have any flu-like symptoms, or especially if you start developing a fever, definitely take Tylenol in that case. Or even ibuprofen if that's your choice. And the reason is you don't want that fever to escalate, because if you're doing well, you could have a breakthrough seizure just because of the reaction of your immune system, just because you're going to develop that fever. It won't mean long-term that you'll have seizures, but over that 24 to 48 hours, you're a little bit more predisposed. But in general, the vaccines have not been consistently shown to cause seizures.
Thank you. I see your hand up. It says iPhone. You can unmute yourself.
Okay, I'm sorry. This is me again.
Hey.
Like the last lady who spoke. I have a 15-year-old daughter, and so it was just diagnosed in January. So I am trying to learn as much as I can. But my question to you, since we're on a different topic with COVID, my daughter actually went to the emergency room for the seizure because it was the first time that I'd seen her have a seizure, and it was a grand tonic-clonic seizure. And anyways, all of her tests have come back normal, but she was positive COVID. And she did the rapid test to be admitted to the hospital with COVID. And then once we got discharged after all the testing, I went and did a PCR test to make sure that was a false, or, make sure that's what it was. And she was in fact positive COVID. I didn't know she had COVID when she had the seizure, but I'm wondering, our doctors up here haven't seen any other cases where COVID has caused a seizure. And in my daughter's case, this is for the only seizure we've seen her have. So I'm wondering if you have seen anything in your practice that is just like COVID related.
For seizures, no. It's a concern because, and I'm concerned looking at this long term, because one of the issues that comes with COVID is that it affects your smell. And so your nerves for smell go through the bottom of your skull, called the cribriform plate, right into the inferior part, lower part of your frontal lobes. And so we've seen some patients have some issues with thinking and processing, attention, concentration, but we've not seen seizures directly as a common thing. We have seen a few seizures come in. We have about now we're down into the 60s, 70s range at UF Health and 20s and 30s at the VA Medical Center. And so we see some of the worst cases, but we've not seen that consistently. That said, again, 10% of the population is prone to having seizures. So in her case, I would be more concerned that it was the escalation of any fever or the reaction to the COVID that actually elicited her to have a seizure itself. Did they put her on medications for controlling the seizures?
Yes, yeah. So they diagnosed her with epilepsy and started her on Keppra. So I just was.
And she's never had a seizure before that?
She did not. No, this was the first one I've seen, and then she had a second one as she was being admitted to the hospital. And the other piece to her story, I guess, is that she bit her tongue in her sleep at Thanksgiving, and I didn't draw any connection to that. So I don't know if they're looking at that as a potential seizure.
And by biting her tongue, was it the side of her tongue or the tip?
Yeah, it was the side of her tongue. Yeah.
Yeah. So what that tells you, if you bite the side of her tongue, usually if it's a focal seizure, when it's during sleep, seizures tend to spread to the whole brain more commonly to cause grand mal seizures. And what happens is that your brain controls the opposite side of your motor function. So when the seizures go into the grand mal phase, she bite the left side or the right side of her tongue? Do you know?
I think it's the right side.
So her seizures would have started from the left side and caused contraction of the right side of her body first before the other side got involved. And so you would bite the opposite side of your tongue. So that would have made me concerned that she could have had a seizure during sleep. Have any of her teachers ever caught her that they caught her staring off and not?
No, there's been no other type of concern at all. She's a gifted student. Like there's nothing else that had been a red flag until I saw the seizure. And then like being in there and talking, she bit her tongue that day. And then being in there talking more, I was like, wait a minute, she just bit her tongue Thanksgiving. That morning she woke up, with a sore tongue. And I thought, so anyways, because I think of that, we have started on medication. Yeah. But I just was curious because, of course, anybody who's dealing with this wants to blame something and know why and what. And, it's just hard, so trying to figure it all out.
And unfortunately, 60% or 70% of the time, we can't give you a definitive reason why. The good thing is most of the time that's good because it means that you're, my experience, more likely to stay seizure free. So again, 10%. So my guesstimate would be that she's probably predisposed. Again, 10% of the population will have a seizure sometime in their life. So whatever was happening around Thanksgiving, and then probably the escalation of the fever and the illness is what sort of precipitated her to have that second event. And so she would be in a situation where, I would tend to agree to at least treat her to make sure that she recovers from everything. They got her on a good medication. Other than having any mood issues with Keppra, Tanya Talton used to be a UCB Keppra person. I used to work with the company quite a bit. It's a good medication. It's a drug I use for my UF athletes because it doesn't cause really any side effects other than some moodiness. If she gets some moodiness, 50 milligrams of B6 usually helps that out.
Yeah, we've started that.
And then, and as a young woman, you want somebody to pick the right drug because her issue is going to be for the next. They may want to keep her on for at least a year to 2 years on the medication. And then she'll have to decide whether or not she wants to come off. May not be a bad time if she's still in high school because then she could taper off and not worry about the driving issue as much. But Keppra is also going to be one of the safer drugs if she ever wants to have a family. You don't want to be on Depakote. So whoever's taking care of her actually did a very intelligent move. You want to put a young woman either on Keppra or lamotrigine, Lamictal, as your top choices for a young woman, knowing that if you get started on a medication at age 15, she may be on this medication because of driving and concern that she might have another breakthrough for the rest of her life. So which city are you in?
Jacksonville.
Okay. I know a lot
Thank
of
you.
doctors out there.
Thank you. And so we have time for one last question. This is from Melissa. She is asking if a pituitary microadenoma can affect epilepsy, or could that be the cause of temporal lobe epilepsy?
Typically not. Usually we find those just by chance. I have had dozens of patients who've had seizures for years. There is it's an unusual pediatric tumor called a hamartoma that can present like that, but those are usually people who are very debilitated. So pituitary tumors we see these very commonly with seizure patients, headache patients, and we just think it's something as a sort of an incidental finding in somebody. Unfortunately, I think my poodle we're going to diagnose this week with having a pituitary tumor too. So they're very common,
no.
very treatable though nowadays for the most part,
Right.
but probably no association between the two as a cause effect.
Okay. Thank you. Well, everyone, thank you so much for coming. On behalf of Epilepsy Florida, I want to thank Dr. Katani, Dr. Eisenshank, Tanya, and Greenwich Biosciences for sponsoring us tonight. And I hope that you guys will join us again next month. Dr. Katani, did you want to have any closing words?
Yes, I want to say a big thank you to Dr. Eisenshank for this amazing conference he gave us today. Very informative. I myself learned a couple new things that I didn't know. For not serious. And I appreciate you all being here. And thank you again for coming, supporting each other. And the only way we could live together and help and by supporting each other and by understanding and fighting ignorance and learning more and more and more. Thank you all. Thank you, Tanya, for sponsoring us. And thank you, Rachel, for being amazing.
Oh, thank you. Thank you. And anyone, if you had any questions that didn't get answered, join us next month, okay? We hope to see you.
See you next
All
month.
right. Have a great night. Be safe, be well.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye. Thank you.